his hands.
Good morning, my lady. May I please call Professor Bangu, who will take the oath.
Thank you. I swear by Allah that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you.
Professor, good morning. You've provided the inquiry with a report with a colleague, Dr. Nepigodiev, titled Unveiling the Hidden Impact of Colorectal Cancer. That is INQ 304742444. Before we start, is it right that you have a small correction to page 22, table 4 of that report in relation to the time frame for diagnosis to treatment in Scotland?
That's correct, and it says 62 days. It should be 31 days.
I'm grateful, thank you. Professor,
Can you just pause, Miss Hunt? I'm so sorry.
Yes.
I can't see a transcript running. Is it just my screen? Is there a transcript?
No, it isn't.
Have you got a transcript? You have got, it's just me. Don't worry, it's just me.
I don't have one either.
Don't worry, it could be fixed at the break for me. But, okay, as long as everybody else has got one, and we have got one running.
Okay.
Sorry to interrupt.
Not at all. Thank you, my lady. Professor, it's correct, isn't it, that you qualified in 2004, trained in general surgery and completed a PhD for research into colorectal cancer?
That's correct.
And you are currently a consultant colorectal surgeon at University Hospital Birmingham Trust and Professor of Global Surgery at University of Birmingham.
That's correct.
We're going to be looking today at the impact of the pandemic on colorectal cancer. That is the fourth most common cancer and second leading cause of cancer-related deaths in the UK. Is that right?
That's correct.
And your report provides data where available for each nation of the UK, which is very helpful. We won't have time to go through each today, so I want to ask you whether you have observed any significant difference in the data between each nation that you wish to set out at the outset.
No, from the data available, the patterns of events across the whole patient pathway appear to be very similar across all the nations.
Thank you. And in regard to terminology, it's correct, isn't it, that colorectal cancer is also referred to as bowel cancer?
Yes.
So starting with the diagnosis and screening of colorectal cancer, it's right that it can be symptomatic, in which case patients will present to their GP or A&E.
That's correct, yep.
And it can also be asymptomatic, and such cases are usually detected through screening.
Yes, for those in that age bracket, of which they can be screened.
And what is that age bracket?
So in England, it's 54 to 74.
Thank you. And briefly, what are the most common symptoms?
In brief, they're things like changes in bowel habits that are persistent and worsening, bleeding out of someone's bottom, what we call rectal bleeding, and some people present with pain and masses in their tummy.
Thank you. And can you briefly explain the tests that are used for diagnosing colorectal cancer and whether any are more effective or suitable than others for certain types of patients?
The first choice test for diagnosis is an endoscopy, which we call a colonoscopy. So that's also known as a bowel scope. So it's a camera that goes into the bottom. It can make a diagnosis based on what the endoscopist can see. And the advantage is it also allows a biopsy to be taken there and then. We perform CT scans in some people who aren't suitable for an endoscopy. So people who are older, more frail, for example. And those are the most two common first-line tests.
And what was the most common method of diagnosis before the pandemic?
Around 50% of patients is symptomatically via their GP, and then they come in on an urgent cancer referral pathway into the hospital.
And did that change at all during the pandemic?
During that first wave, the reduction in diagnoses was predominantly due to the difficulty in accessing the health system, which would have been affected mostly in those patients.
And we'll come on to look at that data in more detail in a moment. it's correct that there was a pause in the bowel screening programmes across the UK from around March and April 2020, which resumed in June to October that year. Is that right?
That's right. And that was timed with the cessation of all elective activity in that period.
And is it your view that that was the right decision to pause the screening programme at that time?
One of our recommendations coming out of this inquiry will be to continue cancer diagnostics, which includes the screening programme, in future pandemics. So with hindsight, the answer is no. I would like to have seen that have continued during that time period.
Can we please have on screen INQ 304742444, figure 21A? We're going to look at figure 21A and B during your evidence this morning, but starting with A, which looks at the number of diagnosis rates in England from 2019 to 2020. Please, can you explain what the data in this graph shows about the diagnosis rate during that period?
So this shows the number of diagnoses per each month over the 3 years shown there, 2019, 2020 and 2021. And the key focus is on the orange bar, which is 2020. And you can see in March 2020, when the pandemic and lockdowns hit, there was a steep drop in diagnoses. And that lasted until the lockdown lifted. And then the diagnoses rapidly increased again to what we'd expect. And that's the key period there. And we think in that period, there were 4,725 fewer diagnoses than would be expected. And that's one of the key groups of patients who were lost in this pandemic.
And how did it recover so quickly?
So this graph shows us that there was a very quick recovery in activity, and that's largely due to the activities of the frontline staff in the GP practices and the hospitals who got back to business and found ways around the problems we had at the time. So we did as much endoscopy as possible, and the endoscopy rates picked up. The scanning rates picked up, and the GPs were able to provide enough access for the patients with these, we call them red flag symptoms, to get back into the system. And so that frontline clinical activity enabled these rates to continue. And then you can see in 2021, there may have been a slight increase in the number of diagnoses expected. And so there was an element of catch up in the system that enabled some of those patients hopefully to have flowed through.
And in your report, you have provided a comparison of diagnoses of colorectal cancer per year across the UK. So if we could please have on screen table 5. Thank you.
Just before you do, I'm sorry to interrupt.
Yes.
You say that you made the recovery because of the frontline staff picking up red flags. As far as the cancer screening and the elective procedures were concerned, had that changed, or is it just that the frontline staff took their own efforts?
No, and so during the pandemic, we still continued to do some cancer surgery, even during the lockdown, because there were patients already in the system, and some were still managing to flow through. One of the main rate limiters were these endoscopies and the camera tests, and for various reasons. And so that was the direct activity of the hospital staff that enabled that to reopen to the highest number per day as possible.
We're going to come on to look at some of those barriers to restarting endoscopies in a moment. Looking at the data we have on the screen at the moment in terms of the diagnosis of colorectal cancer per year, can you explain the crude reduction and crude excess numbers and what that shows in relation to the impact of the pandemic?
And so the crude reduction, that shows between 2019 and 2020. And if you add that all up, that comes to the 4,725 patients we think were lost during that first lockdown period. And so that's based on what we would expect to happen year on year. And it has been relatively stable year on year. So I do think those were lost patients in the system. And then if we compare 2019, that's the pre-pandemic baseline, to 2021, there's an excess. And that largely accounts for those 4,725. So numerically, things balanced out. Now, were they the same patients is a really important question. Not necessarily. It's possible that some of those 4,725 patients were lost in the system and never came back. And some of the excess presentations were other patients entering the system during 2021 when they felt the health system was more open. We can't, there's no data linking all that together at the moment, so that's the best estimation we have. So to summarise, we think that the numbers overall balanced out, but we can't guarantee that there weren't some patients lost in that system.
And in your report, you've set out a number of reasons or potential reasons why, in your view, there may have been fewer cancer diagnoses, particularly in table 12. That's page 58 to 59. Could you just summarise some of those potential reasons for us, please?
One has to look at the patient pathway. So the first perception from patients were that either the GPs were closed or patients shouldn't go to their GPs to overwhelm the system. So some of these patients with symptoms stayed at home and they didn't call anyone, they didn't try and call anyone, they didn't try and contact anyone. There were some patients who at that time did try and contact someone, but because mobility was poor, lockdowns were happening, they couldn't access the system at all. So again, some of those patients gave up and waited until the lockdowns were lifted. So that was the first phase. The second point where people did manage to get through the system, our capacity for endoscopy, which are the camera tests, fell dramatically. So it fell to about 5% of what we'd normally be doing. And so our capacity to provide diagnosis during that period also fell. And so those are the two main reasons why there was a fall in diagnoses in that first phase.
And one of the reasons you've mentioned is that GPs thought that they should reduce or stop urgent suspected cancer referrals. If we could have on screen, please, INQ 40873325. Thank you. This is part of a 17-page letter that was sent from the Medical Director for Primary Care to GPs in England on the 19th of March 2020. It's at tab 24 if you do wish to look at it. The letter was dated the 19th of March 2020 and set out the next steps for general practice. Page 6, which is on the screen, is part of an annex to the letter, headed actions we are taking nationally to free up capacity. And halfway down it states that people who are concerned about any symptoms related to suspected cancer should still contact the GP. And GPs should make sure that they continue to refer those for suspected cancer for diagnostic tests as normal. In your view, was that instruction sufficiently clear and accessible for GPs, particularly given the volume of information coming out at that time in mid-March 2020?
No is the answer. I don't think that information was accessible, nor was it clear at that time. For both ends of the spectrum, the information coming from hospitals and the health service to the GP, and the GP's understanding who they should and should not be sending into hospitals at that time. So, and that reflects an underprepared health system for cancer diagnostics at that time.
You've set out at your paragraph 62 that it is critical to consider the counterfactual position. Can you just explain what you meant by that and why you see that as so important?
It is, and without that lockdown, hospitals may have been even more overwhelmed than they were, and that could have had a lot longer effect on diagnostics. Combined with the fact that if we'd kept elective diagnostics and surgery going at maximum capacity, in at the time what we call a mixed COVID environment, so our hospitals provided elective and emergency surgery at that time point. COVID infections for those patients could have been very harmful. These are often old, frail patients coming for diagnostics, and not all of whom will end up with a cancer. So they would have been very heavily exposed to COVID at that moment in time entering the hospital. So the total harm of that could have been even greater.
And in your recommendations, you've suggested that in future there should be an evidence-based stratifier for diagnostic testing and potentially access to alternative screening and diagnosis options in future. In layman's terms, can you just explain what you mean by that?
So it's one of the things that was coming into place during the pandemic and did help us with the recovery is what's called a fit test. So it's a screening test. It's a home stool test. So patients get posted out a piece of card. Forgive me for being graphic. You get a little stick, you get a little bit of poo, and you smear it on the card, and you put it back in the post. Then that goes off to a lab, and they test it for hidden blood that you cannot see with the naked eye. And then if it's positive, that triggers a referral into the hospital on the faster diagnosis pathway. And those are the patients who progress very quickly to a diagnostic test, which is mostly a colonoscopy. So that is very much come into frontline practice now. It is a good stratifier because if it's a negative test, you're highly unlikely to have a cancer. So it allows us to focus on the positive tests. So in the next pandemic, we should be focusing solely on that group of people with a positive test to match our capacity at that time.
And to what extent were those tests available across the UK during the pandemic?
They weren't as available as they are today. It was being rolled out by the bowel cancer screening programme at that time. And if anything, the pandemic increased the speed at which they were being rolled out. So by the end of 2021, they were far more commonly used than at the beginning of 2020.
I want to look specifically at endoscopy now. As the gold standard test, you've described it as in your report for colorectal cancer diagnosis, and one that, as you've referred to already, was directly impacted by the pandemic. It's correct that there were no specific tools or guidance for prioritising endoscopy before the pandemic, was there?
No, not related to the pandemic. But one of the main focus for that test is what used to be called the 2-week wait pathway. So those are patients who, within 2 weeks of being referred by a GP, they should end up with a diagnosis of a cancer within that time period. So that was a focus for endoscopy units across the country.
And that remained in place during the pandemic?
Yes, it did, and it still is. It's now called the faster diagnosis standard.
Thank you. In your report, you've explained that there was a divergence in guidance that emerged at the start of April 2020. When Public Health England and NHS England were advising that endoscopy could be safely carried out and indeed should be prioritised, and the British Society of Gastroenterology, or BSG, advised suspending all non-emergency activity for 6 weeks, including endoscopy, due to concerns for staff safety, conducting aerosol-generating procedures and the need for redeployment. To your knowledge, which guidance was followed, and was there any inconsistency in approach taken?
The guidance that was mostly followed was from the British Society of Gastroenterology, which advised caution on behalf, really, of the staff working. And it was a combination of the fears of the effects of aerosol generation and also some of the changing recommendations that came around at the time around changing air in the rooms between patients and the time that takes. And in combinations, those slowed down both the total number of endoscopies that could be provided and also within an individual time slot, half a day, the number that could be provided there.
And the guidance from the BSG was updated at the end of April 2020 for the phased safe restart of endoscopies, including measures such as COVID-19 testing and PPE. Were you aware of a delay in services restarting?
I think it did take a long time to get the full breadth of services restarted, and one might argue we're still not quite there. In terms of the number of cancer diagnoses, we did. It looks like we did get back there, and we're back to how we were performing before the pandemic, and that's the combination of what the GPs are doing to refer and stratify patients, that stratifying test. Now all of the faster diagnosis standard test, this what used to be called the 2-week way pathway, the NICE recommends that who make the recommendations over how we practice, that they have this accompanying fit test. So we're better able to identify those with a very positive test and get them into the endoscopy slots. But endoscopy was the hardest hit unit in the whole of this pathway, and there's, even today, the capacity is a struggle.
And you referred earlier to colonoscopies, and is it right that they were also impacted to a significant extent for the same or very similar reasons?
Yeah, so endoscopy encompasses a colonoscopy, which goes all the way around the bowel, and what's called a flexible sigmoidoscopy, which goes halfway around the large bowel.
The Association for Cancer Surgery provided a statement to this inquiry, and they've said that the lack of a centralised system to gather, review and disseminate expertise, for example on AGP risks of endoscopy, caused inconsistency and confusion. Firstly, would you agree with that?
Yeah, absolutely, and it reflects some of what we've said around the provision of endoscopy, the provision of information to the GPs, and then the provision of surgery as well.
And would you recommend that a centralised system be established prior to any future pandemic to ensure that we were in a better place if going into another one?
Yes, and I think 2 key recommendations there. Firstly is centralised communication, which is harmonised and doesn't have too complex a flow, so it can get out to those who need it quickly. And secondly, since the pandemic, this concept of diagnostic hubs has increased. So these are standalone units which can provide scans and endoscopies outside of the major hospitals. And one of our recommendations is that these units need to be prepared for the next pandemic. So if things like communication pathways, testing, they can ramp that up very quickly if this were to happen tomorrow.
You've already covered some of my questions in regard to the cancer screening programme and fit testing. Is it right that there's a variation in uptake of screening across the UK? And is that impacted by geography or demographic?
There is definite variation in uptake, and it's both of those things you said. There's geographical variation. There's variation based on deprivation. So we know that more deprived communities have lower uptake. And then there's variation based on ethnicity, with ethnic minorities having a lower uptake as well. And then there's the intersection of ethnic minorities in deprived areas who have the lowest uptake.
Were they pre-existing before the pandemic, or did they rise or worsen during that period?
They were pre-existing before the pandemic. I think they were present during the pandemic, and they are present today.
And I think in your report, you've given some suggestions as to how they could be reduced in a future pandemic. Could you just explain some of those, please?
Yeah, and a lot of it's around communication, and it ties into communicating around the bowel cancer screening programme now. How do we most effectively communicate it to the patients who are most likely to benefit? But also, if there is another pandemic, how do we communicate to patients that the GPs remain open, that people should take part in bowel cancer screening, that if they have these symptoms, they should seek medical help. And that will require a whole system to address that. It will be the hospitals, it will be the general practitioners, it will be the public health physicians.
I want to move on to staging. You've referenced staging in your report, and is it right that that refers to how advanced a cancer is?
That's correct, the stage at presentation.
And there are 4 stages, with 3 and 4 being for the most advanced cancers.
That's correct.
And put simply, is it right that the rates of survival are better in the earlier stages of cancer when they're seen at presentation?
Yeah, very much, and there's good evidence to support that.
In terms of the data during the pandemic, is it right that it shows that during April to June 2020, there was a small increase in the proportion of patients with advanced disease when there were fewer diagnoses?
That's correct. There was a blip up which came down relatively quickly.
I was going to say, in the proportion diagnosed with stage 3 or 4 recovered by the end of 2020, you've said, when diagnosis returned to normal?
Yes.
Do we know yet if that's had any long-term impact?
No, we haven't got the 5-year survival data from that time period, and that data even then doesn't come out 5 years after the pandemic. It tends to first 5 years has to pass, which is the average of 5 years for the patient. Then the data has to be prepared and published, and that itself can take a few years. So we might not know for a few more years the impact of that time period on overall survival.
You've also said in your report that 20% of data was missing. Are you able to opine as to why that was and what impact that might have on our analysis of the data?
Yes, the data was probably missing because the normal people who would collect that data and input it into the various systems to exist were locked down during that time period, with a large shift to not being in a hospital and not having the system around it to support that data collection. So that's probably why it happened. And the effects are that we don't know. There's some knowledge gaps. For example, there's some data on an excess of deaths at home due to colorectal cancer, and we can't link that all together. We don't know whether that's because of the missing data, or we don't know if that's because these patients were present before the pandemic and died at home. And so that's a really complex area, actually, that I'm aware we might not ever be able to unpick it.
You've touched already on some of the performance and the referral to diagnosis. So I want to continue on that theme. You've set out in your report very helpfully the referral performance standards across the UK and the different metrics and targets. Were those targets met prior to the pandemic?
They were beginning to dip in 2019 across all countries and across all health systems. So they were being met 5-8 years ago, before the pandemic. Then in 2019 they were dipping, and the pandemic has exacerbated all of that.
You've said in your report that it's critical that adherence to cancer performance standard is maintained. Does that include throughout the pandemic?
Yes, we would we and as a community, we'd like to see that happen. I think these targets in the NHS, they can be quite political words, but equally they hold the system accountable. Targets like this come with a whole infrastructure of people behind them: administrators, multidisciplinary team coordinators, and people who can chase tests and ensure they're done. So without that target, that infrastructure is all lost in the accountability. So keeping that target in place and ensuring adherence is one way to ensure that both now and during future pandemics, we're all moving in the same direction and aiming for the same thing.
As a summary of your evidence, I'm looking at your paragraph 71 in relation to referrals for treatment. Is it right that there was an initial fall which recovered around 2020 but didn't exceed 2019 levels?
Yeah, that, if I've understood that correctly, that makes sense. There was a fall in the number. Can I just clarify?
Yes, it should be page 45.
Yep, so there was a fall in the number of operations that took place, which fits with the reduction in diagnoses.
And what about referrals?
Yep, there was quite during that first phase of the pandemic. Sorry.
Yes.
Yep, there was a definite fall in the number of referrals that took place during that phase.
And it recovered around October. Is that right?
Yeah, that's correct. So the number of diagnoses then upticked very quickly, recovered by around October, but it didn't exceed the number of 2019 referrals in the same time in 2019.
You've also addressed this at your paragraph 53, so it may be helpful to look there. That's page 25. And you've set out there some of the reasons for the decline in those referrals.
Yeah, and it's, as we discussed, it's patients were anxious about leaving homes, and these are some of the vulnerable patients with red flag symptoms. So lots of people just stayed in their home for that time period. There was the perception that GP practices were closed, which they weren't, but there was reduced physical access into most GP practices at the time. There was the perception from some GPs that these urgent referral pathways were closed, as we've also discussed. So when we take that, it reflects a lack of preparation in the system and a lack of consistent messaging into the community around patients at risk of these symptoms. And those are the reasons that led to the drop in diagnoses.
Thank you. I'd like to move on to treatment pathways now. You've helpfully provided a long list of the specialised healthcare professionals that are involved in the management of colorectal cancer treatment in your report. And you've placed particular emphasis on the importance of shared decision-making between professionals and the patient and the multidisciplinary team approach. Was that approach impacted by the pandemic?
I think yes, communicating with patients definitely changed and became harder in some ways. Getting patients into the hospital physically for these discussions was a major challenge to some of these patients as well, combined with the stress and strain of the rest of the pandemic. The multidisciplinary team meetings continued, and they did continue on a weekly basis. Not everyone was there because a lot of people were redeployed. I was redeployed during that first phase, but the meetings did still take place by a range of other staff, and that was critical to providing both the surgery that did take place and the oncology treatments that also took place during that time period. And that these multidisciplinary meetings and those pathways should definitely continue in future pandemics.
Was there use of remote technology in order to enable those meetings and the patient involvement to continue where appropriate?
Yes, especially around the staff of that team being able to attend a want-to-meet week meeting, and that still happens now. So it's been a positive impact.
And can you briefly summarise the treatment options and pathways for colorectal cancer? It's set out in full in your report, and I would encourage anybody to have a look that's interested. But if you could just summarise those for us, please.
In brief, most patients will achieve a cure via surgery, and that's surgery to remove the affected section of bowel. There's a small group of patients with a very early cancer where it can be removed at the time of a colonoscopy, avoiding the need for surgery. And then there are some patients who can undergo radiotherapy and chemotherapy to either bring them benefit before or after an operation. And in some patients, that can make the cancer disappear altogether and they can avoid surgery. But surgery remains the mainstay of treatment.
You have posed 5 research questions in relation to surgery for colorectal cancer at paragraph 51. Page 23. Could you briefly just summarise those questions and your findings in relation to them, please?
Yeah, so at the time, we launched a big research response to surgery in COVID-affected environments. And this project led from England gave data to surgeons around the world in what to do. So the first question is was it safe to have surgery in an unselected mixed hospital? And that's a huge question that was of interest to the taxpayer and the general public around the world. And the answer was no, it was not safe to have planned surgery in what we called a mixed COVID environment at that time. We called them hot hospitals. So that was the first question that was answered. And that was one of the key critical questions that is affecting and influencing the delivery of elective care today. Is it safe to have this all in one big hospital where all the emergency infected patients can be mixed in? The other questions around delays for positive patients, we answered that is better to wait for 7 weeks. What about testing regimes? Should they be complicated or simple? We unpicked that. A simple swab would be straightforward for most patients. What is a safe? How long can you wait with cancer surgery before performing the operation safely? We said a maximum of 4 to 8 weeks. That's the absolute maximum we'd be aiming for. And then what are the features of the safest place to have surgery? And we've begun to identify those. Those are COVID-free elective hubs. And those elective hubs are being expanded today.
Thank you. We will return to some of those points, but it's helpful to have that context set out. I want to deal first with laparoscopic procedures in relation to surgery. It's right that there was, again, initially a divergence in the advice from the specialist associations of the perceived risk of an increased aerosol spread of COVID-19 during those procedures. Is that right?
Yes, with most people during that first phase of the lockdown, most organisations eventually saying that they perceived a risk from that procedure.
And so you said some, or most centres, so there was some divergence between the centres as to whether they continue to offer those procedures or not.
Yeah, in pockets, most surgeons for that March and April 2020 period switched to open surgery for the perceived safety risk to the staff.
And is it right that the lower proportion of procedures led to an increase in stoma form of procedures?
They're slightly different questions. So the shift to keyhole versus open, you can do the same operation keyhole or open. So there was a shift to open surgery to protect the staff and prevent this concept of aerosol generation. The shift to stomas was in some higher risk patients because bowel surgery, I describe it to patients, it can be like plumbing, it can leak. And if it leaks, you end up in hospital for a long time. You might have to go back to theatre. So to avoid the risks of all of that, we created more stomas than we would perhaps today to remove the risk at all of these leaks.
Are there any disadvantages to the patients in that move?
There are. Most patients at that time would not choose to have, most patients now or before would not choose to have a stoma. Most of those patients could have got through surgery without a stoma at all. And then the patients have to undergo a second operation to reverse that stoma. So there were disadvantages to that practice.
And I think you said that the rate of the stoma reversal also fell during the pandemic in your report. Is that right?
It did that, and there were some patients left for long periods of time with stomas where we would not normally have left them with stomas for that long.
The guidance in relation to the safety of laparoscopic surgery changed in between May and June 2020. Again, is it right that there was some variation in when there was actual return to the pre-pandemic rates of those procedures being conducted?
So, yeah, there was, as with restarting all technologies, there's a curve to get it back to the existing levels and to the levels that we'd want. And that did take a little bit of time, but it was relatively quick to get back to what the pre-pandemic keyhole surgery rates were.
In your opinion, overall, was there an impact on patient choice of treatment during the pandemic?
There definitely was. I actually, the difference between keyhole and open surgery is relatively minor. The difference between surgery with and without a stoma is relatively big, especially from the patient point of view. So there was an impact there.
And it's also correct that there was a move to administer more short-course radiotherapy regimes for rectal cancer. Is that right? There
was. Then that is radiotherapy can either be given over a 5-day period, which is intense radiotherapy, or it can be spread out over a 5-week period. So again, to keep patients away from the hospital, and also because there weren't as many staff around either, there was a shift toward this shorter course of radiotherapy.
Do we know the impact of that yet on the patient's recovery rates?
No, there's no. That gets so complicated in terms of looking at exactly the type of tumour and the stage and then the survival of that we don't know the direct effects of that yet, no.
Were there any immediate effects on the patient of that change in treatment?
I suspect some patients found it a lot easier to have 5 days of radiotherapy rather than coming back to these COVID-infected sites over a 5-week period. In terms of the biology, we've got no evidence that it had a positive or negative effect, and we'll have to look at that in the future.
if we could have a look at your figure 21 in relation to the number of resections. Thank you. So this is the second half of the graph that we were looking at earlier. Can you just explain to us what this shows in terms of the number of resections in England between 2019 and 2022, please?
Sure, and it's consistent with the diagnostic data. There was a fall in the number of resections performed in that first phase of 2020, which is the orange graph. Now, it wasn't as steep as the fall in diagnoses because there were already patients in the system, and it didn't fall down as low as the number of diagnoses because there were still some people coming through emergency routes and other routes who we managed to get into surgery. So surgery did continue throughout the pandemic. It was often in different locations, so we used private hospitals a lot for this service because we didn't want to do these operations in the big COVID hospitals. But again, combined, the frontline teams and that flow of patients kept some surgery going.
Does this include elective and emergency surgery, this data?
Yeah, that includes all of the resections done, the electives and the emergencies. So the emergency patients still presented to A&E departments in desperation, but as described, there were still some elective patients coming through.
And I think you've said in your report that there was no major shift observed to presentation via an emergency route during the pandemic. Is that right?
That's right. There wasn't a sudden increase in the number of patients coming in. It was really proportionate to what we'd normally expect.
And were healthcare professionals supported or advised on how to manage any changes to the MDT decision making and treatment pathways?
There was guidance. Well, there was some guidance from associations and around timing of surgery and priority of surgery, but things like stoma rates were largely made by individual surgeons at the time on discussion with the patients and what the patients would tolerate and what they wanted and how fit they were. So incomplete guidance is how I would phrase it.
That brings me on to the next topic of prioritisation guidance. Thank you. So there were no specific tools for prioritising surgery before the pandemic, was there?
No.
And it's right that there were two types of prioritisation that emerged initially from NHS England and NICE as to patient prioritisation for systemic anti-cancer treatment and then surgical prioritisation. Is that right?
That's right.
And I think you've said in your report that the dissemination of that information from NHS England was delayed, which you have attributed to a lack of system-wide preparation, which you've already touched on this morning. So is that a fair summary?
Yes, that's right.
Quite quickly after that guidance was issued, on the 9th of April, the Federation of Surgical Speciality Association was asked to provide guidance and issued it on the 9th of April, setting out 4 priority levels for surgical prioritisation.
Correct.
That was then updated, and the NHS England advice was also updated in line with that. In relation to colon cancer and rectal cancer, it advised that surgery could be delayed by up to 3 months. So that's outside your 4 to 8 week period that you had advised. Did that raise any concerns?
No, I think from our point of view, if we were to say a delay of 2 to 3 months is the maximum that we would be looking for, I'd consider that to be consistent advice. I don't think those extra few weeks there for this type of cancer make that much difference. We never try to get people to the maximum. We try to get people through the system as quickly as possible. So the number of people with a diagnosis and an MDT decision who get to 2 to 3 months down the line is very small.
Did that guidance help professionals make those ethical prioritisation decisions, in your view?
I think so. That advice by the Federation of Surgical Associations was important, and it was quite one of the things that they did well was that it was quite holistic, so it covered a whole range of procedures. all surgeons want to sort of fight their patients' corner and advocate for their patients and get them into operating theatres, but under severe resource constraints, someone has to make a decision about who's going to use that. And that framework really allowed us to do it more objectively than if each hospital had tried to do it themselves. So I think that was very welcome, and I think that should be part of the future pandemic response as well.
Was there any confusion caused by the multiple guidance documents that were issued around a similar time?
Yeah, I think so, definitely. And we've already touched on some of the associations issuing guidance. And then there were updates to the guidance and the hospital-specific guidance. So it definitely was a confusing period for the frontline teams. And I think that, again, that reflects the lack of preparation for elective cancer care.
To your knowledge, are those prioritisation frameworks still being used in the UK?
Yeah, we still use them to help guide and prioritise patients into operations and around the concept of waiting lists. They're not used as perhaps as directly as they were. So by that I mean that the capacity to provide all types of surgery is obviously higher than it was. But they were useful, and they do remain useful as well to keep patients on track and keep cancer patients as high priorities.
Moving on to the topic of preparedness, in your report you've described a surgical preparedness index. Perhaps you could just very briefly, in layman's terms, just explain what that is.
It's a 23-point assessment tool that clinicians can use themselves to assess their hospital across a range of features and come out with a score, and then see where their weak areas are, where their strong areas are, and where they would potentially rank amongst everyone else.
And in your report, you've described the performance and those points of 170 UK hospitals compared with 119 countries. We don't need to explore each country and each score, but perhaps you could identify the areas where the UK scored the highest and lowest. If it helps, it's table 11, page 55 of your report.
So we, at that time of the pandemic, we scored lowest around ring-fenced care. So that is ring-fenced elective care means physical locations and staff who are dedicated to the task. So the ability to have ring-fenced elective surgery beds that aren't going to be cancelled because of the pressures from an emergency department. The same for the critical care units and the pressures that will again come from an emergency department, but also staff who aren't redeployed to other areas. And that actually tends not to be so much the surgeon, it's the theatre nurses, it is the anaesthetist who might have to go and support other areas of the hospital. So ring-fenced staff and ring-fenced beds were where we definitely scored weakest, and that's where some of the response has been to strengthen those areas.
And perhaps where we scored highest?
Yeah, and actually globally we scored highest around the reliability of things like electricity and oxygen and drugs, which we are lucky enough to take for granted. But we know from places like Nigeria, the operating theatre has 7 power cuts a day. So we are lucky to take them for granted, and I'm glad about that.
And you've set out in your report in a helpful diagram that there was also regional variation across the UK in your findings. Is that right?
There is, and there was, at the time of that study, there was regional variation, and we can see areas of the north of England perform very well because they already had some concept of elective hubs there, which were not present in the rest of the country. And that regional variation probably remains today, but it's definitely being strengthened by this concept of diagnostic hubs, which are meant to be small community-based environments to provide diagnosis, but also the 20 or 22 such elective hubs that are being set up around the country, elective surgery hubs. These are hubs that are meant to be physically separate from hospitals' A&E departments, and they can provide elective surgery at volume without the risk of cancellations. And that strengthens the area of ring-fence care.
Could this index be used to prepare for future pandemics?
It definitely could. It definitely should. it was designed to be relatively easy to collect and not onerous, which is really important for frontline staff who are doing these things. But it also empowers frontline staff to try and make some of these changes.
You've referred to the hubs and the COVID-free pathways a number of times already. Could you just set out the extent to which they were available and used during the pandemic, and perhaps briefly where we are now in the development of those hubs?
So on sort of day one of the pandemic, they didn't exist. Very quickly, capacity was ramped up to provide this type of surgery, predominantly in private hospitals. Where these hubs did exist, like the Marsden and the Christie and some of the centres in the north, they continued and they became regional hubs to provide this type of surgery. And they were able to provide all the testing and the things needed to get someone ready for a major operation. Today, there are more hubs in existence, and the model to provide that type of surgery works. They're not. You still need the major hospitals. If a patient needs a big operation, they've got heart and lung problems, and they're very old and frail, they still need to be in one of the big hospitals that has a huge ITU, has a big radiology department, and by definition, those hospitals have A&E departments. So these are ring-fenced, but they can't stand alone from a major hospital. Also, if the patient needs to go back to theatre at night for an emergency reason, again, you need that big hospital to support that process. So those are being expanded today, and those are definitely part of the future of the NHS.
Do you have any recommendations about how they could be used better in a future pandemic, or perhaps ring-fenced, as you've suggested?
Yeah, and it's about getting them prepared as well for the next pandemic. At the moment, quite rightly, those hubs are focused on waiting lists and flow and diagnosis. But if a pandemic was to hit tomorrow, they'll still have the problems over communication, pathways, PPE, testing, communication with the general public. So having plans in place now will mean that if that happens, they can rapidly adjust without the pains that happened the first time.
You've recommended an increase in public-private partnerships in the future in your report. In your view, was the independent sector utilised to its full potential during the pandemic?
I think it definitely fulfilled a role then, and it was used to the potential that we needed it to be used. I think that since sort of drafting this pandemic and how the hubs have developed, the hubs will provide a more reliable, cost-effective solution to this problem. And I think that the private sector should still be engaged. It's this private sector capacity, it's the physical facilities to provide additional capacity if needed. But actually, as the community hubs open and the elective surgery hubs open, they should provide the bulk of it now.
Moving on to a slightly different topic. Was there any evidence of cancer patients receiving chemotherapy or other treatments being at an increased risk of mortality from COVID compared with those not on active treatment?
I don't think there's any evidence to suggest that they were at any excess risk compared to what they were anyway. A lot of those patients took quite extreme precautions around their lives at that time period. So they isolated very aggressively. They didn't see families. They travelled to and from very carefully. So that probably protected them at the psychological cost.
And in your report, you've set out the ONS data on excess deaths for England and Wales from March 2020 to December 2022. I'm at your paragraph 77, if it helps. But is it right that you have surmised that there was 1,630 excess deaths from colorectal cancer and anal cancer compared to what would have been expected on a 5-year average?
Yes, and that's what the data says.
And that there were 4,445 more deaths from the same cause at home than would have been expected.
Yes, but I'm quite cautious about that data. It doesn't tally up with when we were looking at the graphs around the lost diagnosis and then the recovery in 2021. So those graphs suggest that the numbers matched up and the number of diagnoses was eventually caught up. And this data suggests that that's not necessarily the case. That's because this data probably represents some patients who have had cancer before the pandemic, never presented to the hospital, were never going to present to the hospital. We don't quite know during that time period how some of the death certificates were being completed, with a complete drop in post-mortems being performed, again, because of the same concerns. Some of the death certificate completion, I'm uncertain about it. The data's not age standardised. So I'm cautious around that figure. I would like to see more research into that in the future if that was possible.
And for completeness, was there any data available for Scotland or Northern Ireland to include in your report?
Not beyond what we've found from the ONS, so no.
Thank you. Moving on then to your recommendations. Now, you've set out quite a few as you've gone through your evidence this morning. We also have a number of very helpful recommendations and solutions in your report. There are two topics that I'm conscious we haven't covered, that's IPC and research. Are there any key points in relation to those two that you wish to comment on?
I think for your first one, infection prevention control, I think we've got a much better understanding now around the risks around colonoscopy and laparoscopic surgery. So I don't think we'll have those debates again, hopefully in the phase of a new pandemic. However, understanding the pathway by which these associations can give that communication out, make these decisions and communicate it, is worth setting up now, so that there's not the mixed messaging. So that's number one. And research, I think that the preparedness for the hubs, the preparedness for communities will be best done by the research. For example, I talk about communicating with communities over cancer symptoms. We don't know how best that is done. When I first thought about it, I thought, the GPs can do that. But that is not necessarily the right thing to do. The GPs probably have a completely different role in this. And the communication to the public around how pathways and practices and hospitals will remain open, we need to better understand how that's done, how is it cost effective, and how is it best received by the communities, especially from our earlier comments around disparities with certain sections.
And then finally, are there one or two headline recommendations from everything you've said this morning, or solutions that you wish to draw our attention to?
Number one, we should adhere to these cancer performance standards. And I think we will see more emphasis on these targets over coming years rather than less emphasis. So number one, in the next phase of the pandemic, we should do everything we can to adhere to those. Number two, we should, in that pandemic, focus on fit testing and really prioritising patients with a positive fit test. So making sure those pathways remain in place to get fit tests out to patients. And then number three is the continued delivery and preparation of the elective hubs and diagnostic hubs, which will be critical to maintaining capacity. For example, we can send out all these fit tests, but if we can't do anything about it, it's pointless. So we really need well-prepared, well-staffed hubs to take that burden.
I'm grateful, my lady. Those are all my questions.
Thank you. I think there's just one question from Mr. Thomas, who's behind you. Could you make sure your answer's still going to the microphone? Thank you.
Professor, I only have the one question. My name's Leslie Thomas and I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations. This was touched upon in your evidence just earlier, but I just want to go over it if I may. Professor, in paragraph 34 of your statement, you note that cancer symptom awareness tends to be lower in ethnic minority communities and suggest that targeted interventions could help to reduce this problem. Here's my question. During a pandemic, how can healthcare systems ensure that public health messaging and services are culturally tailored to meet the needs of ethnic minority communities, particularly in relation to cancer care?
I think that's a really critical and good question. My answer to that is tied into that. I would like to see relatively urgent research done that actually involves those communities in telling me and others how it should be done. I think if I tried to create that type of messaging to communities, I probably would not do a very good job because it will not be culturally and contextually specific enough. So my answer is I would like to identify, I think we need a research program to identify community leaders who can create those contexts. The other point is we've learned that one method will not match all different types of communities, and the messaging will need to be different for each community. And so it's really important we don't just paint this with one brush. My opinion is that the only way to deal with that is through a research response. And we're lucky enough to have the NIHR in this country, the National Institute for Health Research, who have some of the world's best applied research pathways. And I go as far as to say that's the only way that we're going to communicate more effectively with those populations.
Thank you very much.
Thank you.
Thank you, Milady.
Thank you, Mr. Thomas. Professor, can I ask you a slightly different subject? You mentioned at the very beginning that you were redeployed at the beginning of the pandemic. You're a bowel cancer specialist, if you'll forgive my using bowel rather than colorectal, and surgeon, and you save lives by early intervention. Were you consulted about being redeployed?
As a department, we made decisions, and I was part of that decision-making process. And those decisions were that the older surgeons would go and do the elective operating. It was considered to be a safer environment, and the younger surgeons would take on the emergency work. So we made those decisions. We made within our department. The redeployment decisions, no, those came from the top of the NHS. And I don't feel upset about that. I'm glad to have been part of that response. I think due to the lockdowns and the other thing that's happened, we probably don't need such a severe response again, and we can actually focus our specialist doctors more on their specialist activities next time.
And where were you redeployed to?
It was to the emergency surgery service, which was remained busy. It's all the things like appendicitis, through to blocked bowel, through to people bleeding. There were a number of traumas coming through the doors as well, because some people still carried on with their activities and people are still driving cars. So the wider effects in the hospital, the wider emergency service was still in place and still needed a tremendous amount of support.
Thank you very much. I'm sorry to ask you. You probably weren't expecting that, given you come here to give evidence as an expert, but I just thought it'd be interesting to know. Thank you very much for your assistance you've given to the inquiry, both in preparing your report and in your evidence today.
Thank you.
Thank you. I shall break now and return at 11:20.
Apologies, my lady.
Mr. Fireman.
May I please call Professor Metcalfe and Miss Scott, who will swear and affirm respectively.
I do solemnly, sincerely and truly
Declare and affirm
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth, and nothing but the truth.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth. Thank you.
I hope we haven't kept you waiting, or if we have, not for too long.
Not at all.
Not at all.
Could you please give your full names?
Mine is Professor Andrew John Metcalfe.
Chloe Elizabeth Henderson Scott.
Thank you. Professor Metcalfe and Miss Scott, between the two of you, along with support from Mr. Catherine and Miss Dife, you have produced a report on the impact of the pandemic on hip replacements. We find that at INQ 304744262. If I may begin with your professional roles, Professor Metcalfe, you are a Professor of Orthopedics at the University of Warwick and a consultant orthopedic surgeon at the University Hospitals Coventry and Warwickshire NHS Trust. Is that correct?
That's correct.
Miss Scott, you are a consultant hip, knee and trauma surgeon at the Royal Infirmary of Edinburgh, NHS Lothian. Is that right?
That's correct.
And you're also an NHS Scotland research clinician and an honorary senior clinical lecturer at the University of Edinburgh.
Yes, that's correct.
For the purposes of producing your report, in addition to reviewing relevant literature and evidence, is it right that you also spoke to a number of NHS staff across the country to get a sense of the clinical realities of hip replacements during the relevant period?
Yes, that's correct.
I'm going to ask you about a number of the topics which you've covered in your report. Broadly, these will be an overview of hip replacements during the relevant period, the impact of the pandemic, both on patients requiring hip replacements and staff involved with the provision of orthopedic care and elective care, the health services resilience and lessons learned and future recommendations. You have agreed amongst yourself which topic you're going to deal with, and I will try to direct the questions to whichever of you is best placed to deal with those particular topics. So if we can start with you, Miss Scott, and some, or would you prefer to be called Dr. Scott?
Miss Scott is fine.
Whichever you prefer.
It's fine. Miss Scott is fine.
Surgeons are Mr, aren't they?
Yeah, I thought
Miss,
Miss.
yeah,
Yes.
Miss.
That was my understanding, yes. Just in case, worth clarifying. If we could start with you, you explain within your report the way in which the hip socket works. It's a ball and socket joint you describe, and there are a number of different conditions that can lead to it being worn out and a need for a total hip replacement. If we could look at your report, this is INQ 3047462, and this is a picture that you have put in your report. Could you relatively briefly just explain what a total hip replacement involves?
Sure. So the hip joint is one of the biggest joints in your body. It can wear out due to various different causes. Osteoarthritis of the hip is very common in an aging population, so very common in the over 60s. But there are other reasons that your hip joint can wear out sooner than normal. So obviously rheumatoid arthritis and other inflammatory type conditions can cause it as well. But there's a number of conditions of childhood and adolescence that can cause your hip joint to form in an altered shape, which make it more likely to wear out sooner. So this tends to generate a lot of pain in the hip joint that people feel in their groin, down their thigh and into their knee, which ultimately limits their mobility and their ability to work, care for their family, sleep, lots of activities of daily living. So fortunately, we have hip replacements, which are probably one of the best treatments in all of medicine in terms of restoring patients' health-related quality of life. That involves removing the worn-out bit of the socket, so the ball comes away. That gets replaced by a metal or a ceramic ball on a metal stem that gets fixed into the femur, and then the socket gets replaced either with plastic that's cemented in, but most commonly a metal socket with some kind of liner inside. So instead of bone rubbing on bone, which is stiff and painful, they have an artificial joint which should be pain-free.
In terms of the most common reason to require a total hip replacement, is it right that is hip osteoarthritis?
Yes, that's correct.
Can you assist with roughly what proportion of the population experiences hip osteoarthritis?
So radiographically, so if you take x-rays of everybody over 60, probably half of them have radiographic changes of hip arthritis. That's not that 50% of the over 60s are suffering from hip pain, but I think in our report, approximately 8% of the UK population over 45 have sought treatment for osteoarthritis of the hip. So it is a very common condition that fortunately we have an excellent clinically proven treatment for.
Does it follow then that hip osteoarthritis is a problem which predominantly affects an older population?
It does, but slightly different to knees and shoulders and other large joint arthritis. Because of the kind of childhood diseases of the hip that you can get, it can affect younger patients, and that is important because it affects working age patients, many of whom kind of put off having a hip replacement for as long as possible because hip replacements don't last forever.
That can come down. Your report describes several measures which are used to assess patient outcomes and patient experiences. And you've set these out, including, I don't know if it's PROMS, PROMS, patient reported outcome measures, the Oxford Hip Score, the Euroqual 5D score. Briefly, what is the value of these scoring mechanisms?
So hip replacements are very common. We do 100,000 of them a year, normally in the UK. If you're doing that volume of something, you need to know if it works or not. So there are a number of validated, heavily validated, in fact, patient-reported outcome measures within orthopedics and particularly within hip and knee hip and knee replacement. And hip and knee osteoarthritis. So the Oxford Hip Score is the score that's most commonly used in the UK as a measure of hip-specific pain and function. The EQ5D, the Euroqual 5D, by contrast, is a validated measure of health-related quality of life. So that is important because all of the conditions in medicine can be measured using health-related quality of life. So anybody can do an EQ5D score, and in fact, it's how cost-effectiveness of a treatment is calculated. So the amount of health-related quality of life you gain from being on a certain treatment lets you compare, you know, a blood pressure medication with a hip replacement with a cancer drug.
Without going into the background in terms of how we get these scores, is it right that generally the way in which it's calculated is that the figures that are given to a Euroqual 5D score are from 0 to 1, and if you are closer to 1, you have a better health-related quality of life, and if you're closer to 0, you have a worse related quality of life?
Almost. So it goes from minus 0.594, so 0.6, up to 1.
Right.
So 1 is perfect health. 0 is supposed to be death. And the negative scores are termed as a health-related quality of life state worse than death. And that's not worse than death according to us as researchers or clinicians. And it's not that the patients say living with this pain is worse than death. It's that those scores have been given to the UK general population, and they have been asked, if you had this score and these symptoms, how long would you be willing to carry on in that health state? And if the general population are not willing to carry on in that health state, then it's one of these negative worse than death scores.
If we could look at your report where you've set out some of the comparisons of conditions. This is on page 13, figure 2. You have here a series of different conditions and the mean Euroqual 5D scores. If you wouldn't mind, could you just explain what we can see in terms of the comparison here?
Sure. So we did a study based in Edinburgh on 4,000 patients, 2,000 of which were awaiting hips and 2,000 of which were awaiting knees, to look at what their health-related quality of life was prior to hip replacement. And that is that first bold result there. So awaiting total hip replacement pre-COVID, the mean EQ5D score was 0.39. So it's not a negative score, but it's a lot worse than other EQ5D scores that are reported for other chronic health conditions, like type 2 diabetes, chronic obstructive airway disease, asthma, heart failure, inflammatory arthropathy, which is things like rheumatoid. Because the EQ5D score is used across the health system, you can get these scores for lots of other conditions which could have been included in this graph, but weren't. We then repeated our study or a similar study, but this time across 10 centres during the pandemic to see how people's health-related quality of life had changed during the pandemic when they were waiting for a total hip replacement. And you can see there the mean dropped from 0.39 down to 0.24. And one of the important things about that is really the number of patients who had these negative worse than death scores. So prior to the pandemic, when the waiting lists were about 3 months for a hip replacement, a fifth of patients waiting for a hip replacement had a negative EQ5D worse than death score. But during the pandemic, that increased up to a third.
Where someone has hip osteoarthritis, taking that as the most common reason for a hip replacement, prior to having the offer of a hip replacement, what are the ways in which a patient in those circumstances will be treated by the healthcare system?
So people can access care for hip arthritis from different sources. Some go straight to a physio, have a period of physiotherapy. Some might see an osteopath or a chiropractor. Others will go straight to their GP. In terms of the management for hip arthritis, when it's early on or when the symptom burden is not too significant, obviously simple painkillers, activity modification, physiotherapy, weight loss, things like that are what are initiated in the first instance. The problem comes when those more conservative treatments and walking aids and things like that aren't helping people live their life as they want to anymore, at which point a hip replacement is what would be considered.
So in the circumstances in which those first options are not successful, at that point a hip replacement will be offered?
Yes.
Are there circumstances in which a hip replacement will be offered as the first course of treatment?
So if the first time somebody comes to see their GP, they have debilitating groin pain that limits their ability to function in day-to-day life. They can't work, they can't get in and out of a car, they can't get in and out of the bath, they're needing sticks or crutches, they're needing strong painkillers, not just simple ones. Opiate medication, lots of people end up on, even though it doesn't work for arthritis. So often people wait until they're at that point before they see their GP, or before their GP refers them to us, in which case we would offer them a hip replacement the first time we see them.
Following from that, is it right that there is a direct link between delay and the progression of the hip osteoarthritis and the symptoms that are experienced directly?
So it doesn't always follow the same course. So some people can have mild arthritis and they can have mild arthritis for years. Some people can have mild symptoms and then 6 months later they're in dire straits with a hip joint that is collapsing. So it is not that all patients follow the same course, but in general, over a period of time, which is variable, the symptom burden increases as the wear and tear or whatever changes get progressively worse. It is true that once patients are at a point where they would be offered a hip replacement, they do then deteriorate markedly while they wait for one. They've already got severe disease and a severe symptom burden, and that's why they've been offered a hip replacement, and they then tend to continue that deterioration. So the longer they wait, the worse they get, and then the worse the outcome of their hip replacement is.
When you first described what a total hip replacement was, you described it as a very effective form of treatment. Is that because for most patients for whom a hip replacement is recommended, provided that that treatment is done within a reasonable time, it is a very successful way of removing their pain and getting their life back to a much higher quality?
It absolutely is. I mean, patient satisfaction a year after having a hip replacement is 93 to 95%. In terms of the gain in health-related quality of life and the quality of life years gained, it is one of the best treatments we have in all of medicine.
Given what you've said about the impact on people's lives when they are awaiting total hip replacements and the potential effectiveness of the treatment, is there an issue perhaps in the way in which this treatment is described, in that it is called elective care rather than perhaps planned care?
Absolutely. I think there's a real disconnect between most patients' experience of having bad hip osteoarthritis and what the public perception of it is. I think, and that goes across healthcare, non-orthopedic healthcare as well. I think many people think, oh, if you've got arthritis in your hip, you maybe can only manage 9 holes of golf instead of 18 holes of golf. And that may be the case for some patients, but that is not all patients with hip arthritis. And if the hip starts to collapse, it can become rapidly debilitating, with patients ending up housebound, wheelchair bound, and then never being able to get their mobility back. So it's a condition that has an incredibly well-validated clinically and cost-effective treatment that really shouldn't be left to that level.
And just concluding this area, Ms. Scott, is it right that there is research that you have looked at that also links the impact of waiting on the mental health of patients who are waiting for total hip replacements, and indeed then the outcomes of patients who have experienced anxiety and depression, perhaps due to or for other reasons, while awaiting a total hip replacement?
Yes, so there's very close links, obviously, between having a chronic pain condition and having a depressive or anxiety and depression symptoms. But specifically for hip arthritis patients, we've looked at a group in Northern Ireland who've unfortunately been waiting 3 years for a hip replacement, and their levels of depression shoot up as they wait, as does their amount of opiate use, so which kind of further exacerbates any depressive symptoms. And we've done studies prior to the pandemic and since the pandemic demonstrating that the worse your scores are preoperatively, the worse your post-operative scores are. So leaving people to get into these terrible health states with frailty and poor mobility comes with a cost, and that is that they never get the outcome from their hip replacement that they would have got had they had timely access to treatment.
Turning now to the changes to and suspension of elective care during the relevant period. And if I can turn to you, Professor. First of all, the inquiry has heard about the decision that was communicated in mid-March 2020 across all 4 nations in various different guises to suspend elective surgery. Do you think that initial decision was a justified one?
Yes, I think that was justified for 2 reasons. Clearly, there was a huge resource burden on the NHS which needed to be managed, and that was entirely necessary. But we should also recommend that patients were in real danger at that point as well with elective surgery. So to put this in context, the normal rate of dying from a hip replacement is between 1 and 3 in 1,000. Very unlikely, and that's across everyone, including the more unwell patients who have hip replacements. The early data coming out of the pandemic was that if someone had COVID, which we of course may not be aware of, and had an elective joint replacement, their risk of mortality was about 1 in 5, about 20%. So in fact, patients were at huge risk at the start of the pandemic, both from COVID and indeed just from the capacity of the NHS. So the decision to suspend surgery at the start was, I think, entirely appropriate.
That's a similar thing to the evidence we heard previously from Professor Bangu. Presumably the messages are the same across elective surgery in the orthopedic sphere as they are within...
Indeed. In fact, the key piece of evidence that Professor Bangu, led the authorship of, in fact, and presented was the same piece of evidence that drove the COVID surge. The COVID surge document was the key piece of evidence that drove changes in elective surgery across the world.
Turning, though, then to the restoration of elective surgery, can we please go through the individual approaches of each nation? And I'll start, Professor, with you, with England. are you aware of the steps that were taken? First of all, we had the decision in March 2020 to suspend elective care. I understand there was then a letter from NHS England on the 29th of April 2020 encouraging trusts to consider whether they could resume elective care. Is that right?
That's right.
And there was then a further letter which we're going to look at on the 31st of July 2020 from Sir Simon Stevens and the then COO Amanda Pritchard. So if we get that up, that's INQ 3005140740. Sorry. So this is the letter which went to all NHS trusts. If we could go to page 3, please. We see under the heading accelerating the return of non-COVID health services, making full use of the capacity available in the window of opportunity between now and winter. And then if we come out of there and we go to A2, recover the maximum elective activity possible between now and winter, making full use of the NHS capacity currently available, as well as recontracted independent hospitals. And then over the page, if we could enlarge the bullet points, please. On the screen, you should see the targets that were set out in September for at least 80% of last year's activity for both overnight electives and for outpatient/day case procedures, rising to 90% in October, and then swiftly a return to at least 90% of last year's levels of MRI/CT and endoscopy procedures. Some of these things will not necessarily directly apply to elective care, some of them might, and then 100% of last year's activity for first outpatient attendance and follow-ups from September through to the balance of the year. Taking that down, in your view, was setting out this pathway in such clear fashion a useful exercise?
I think it was a useful exercise, yes. I think it's clear both from just the letters but also the submission from NHS England to the inquiry that actually there was planning for this from quite an early phase, from at least March 20, if not earlier. And there was at least a directive to restore capacity. Now, whether or not trusts could achieve that or not was hugely variable, and we'll talk about that, I'm sure. But it was at least a directive for trusts to do what they can to do it, which I think was helpful. I think there was a separate issue, of course, which is the practicality of doing so. So this is developing safe pathways for care so that patients can be managed safely, and the ability of different units to do that, and then their resource availability to deliver that care, which was, the availability of theatre staff and anaesthetists and theatre facilities and spaces that you could deliver green pathways in, which were green pathways, the sort of safe pathways that patients could have where their COVID risk would be very low. And the ability to deliver that was a challenge. But yes, the central guidance definitely motivated that and motivated trusts to invest and focus on that, which I think is a really important step, because it's the ability of trust to focus on the need to do it was a real key step, I think.
And if we could go back to that letter, please. Just under the bullet points, there is a series of paragraphs. The third paragraph, which says this underneath the bullet points: trusts working with GP practices should ensure that between every patient whose planned care has been disrupted by COVID receives clear communication. So did you understand that to be a mandate that trusts essentially get in touch with patients whose care has been disrupted?
I think that was probably applied variably, and as that could be interpreted by different trusts in different ways, but I would imagine many trusts would be writing to their patients at that point.
Okay, that can come down now, please. Thank you. Is it right that in addition to that, and this is something you mentioned in your report, NHS England also took steps to incentivise trusts with specific funding, were they to recover 70% of their 1920 baseline by April 2021? Could you just explain a little bit about how that worked?
Yes, so in 25th of March 21, they released a letter which was part of an operational planning guidance that included details of £1 billion worth of elective recovery fund funding. But it was predicated on trust's ability to restore certain levels of activity. That started at 70%, and then the expected percentage rose over time. But there was definitely a clear financial incentive to restore activity in NHS English trusts.
And what is the benefit of doing something like this, of incentivising trusts? I mean, it's perhaps obvious it gives them a direct financial incentive, I suppose.
Well, yeah. So I think, as Chloe said, it's easy to have this belief in a health service that hip replacements aren't important and that elective orthopedic care isn't important. And actually, patients are suffering terribly. They're just suffering terribly quietly at home where you don't see them. Now, having a financial incentive means that there is a direct focus on the ability to treat those patients. So, yes, it gives trust a real focus. And so, we've been in a situation of hundreds of thousands of people suffering quietly at home, unseen, and those patients are focused on when you deliver financial incentives. And if you don't, it's very easy for trusts to not focus on those because they have operational pressures. They have many other pressures they have to deliver on. And we've got to be very sympathetic to the fact these are not trusts in an easy, unchallenged situation. They're under a huge amount of pressure. So, yes, I think it allowed a focus on a group of patients that could easily be forgotten.
Turning now to Scotland, Ms Scott, was a remobilisation plan for elective care made in Scotland?
So it was. So in July 2020, there was a remobilisation plan that was made in collaboration with individual health boards. The issue, or rather the difference between the Scottish plan compared to the English plan was there were no specific targets that went along with it. So there was no, you need to restore 80% capacity. So there were no numerical targets, but also they left the decision to restore elective surgery capacity to two individual health boards who could decide whether to prioritise that in their recovery plan or whether they wanted to continue to prioritise the front door. So the front door is acute services, so the emergency department and acute medical admissions, which of course at the time were very much overwhelmed. So without any financial incentive, without any specific targets to encourage the health boards to restart their elective surgery, there wasn't much pressure on them to do so. So many of them did not really push to restart elective. And then later that same year, in fact, in December 2020, the Chief Medical Officer in Scotland again issued a statement that all elective operating should be ceased. And it wasn't until I think July 2021 that the formal kind of recovery plan was published by the Scottish Government. And interestingly, the recovery plan again didn't really include specific targets of restoring capacity, but rather focused on the delivery of national treatment centres, which had already been planned prior to the pandemic as being necessary for delivering for the ageing population. So it wasn't additional capacity to respond to the backlog from the pandemic.
We'll touch on geographical variation in a moment, or later on, but does it follow from what you're saying that the lack of bespoke targets for Scotland across the board may have risked further local variation in response?
Well, I think the decision was specifically left to health boards. So by definition, it was creating geographic variation. And in fact, two health boards performed very well in restoring elective capacity, and everybody else performed very, very poorly.
Are you aware of whether there was a similar incentive provided to health boards to the one that NHS England provided NHS trusts?
So I am not aware of a similar statement of specific financial incentives going into Scotland. There is a different setup in terms of how joint replacements are normally funded in Scotland compared to England. And I think that culture whereby in England trusts can make money from doing lots of joint replacements well because they then get paid the tariff for doing those joint replacements, that same culture and kind of internal market doesn't exist in Scotland. In Scotland, it's rather, this is your budget, and if you're spending it on hip replacements, you're not spending it on cancer or the emergency department. So there is a different, there's a different approach.
Does it mean that it's harder to incentivise health boards to take on additional orthopedic cases?
I think very much so, unless you are a specific treatment centre.
Turning back to you, Professor, and looking at Wales, if we can go to a witness statement of Judith Paget, this is INQ 304866014, and paragraph 630. This sets out the way in which elective hip replacement was dealt with. It says here, it was by definition not considered to be urgent, and as such, it was for local health boards to decide when to continue to provide such elective surgery, based on an assessment of whether it could be done safely and without compromising their ability to respond to COVID-19 patients and deliver essential services. Reading that, does it follow that in Wales a similar approach was taken to that of Scotland, in that it was left to local health boards?
Yes, that's consistent with the health structure in NHS Wales. It was considered appropriate that trusts should individually make decisions about the provision of orthopedic care. So in many ways, very similar structure to Scotland, and I think that varied a lot between trusts.
Are you aware of how the process of, or if the process of target setting took place for return of elective care in Wales?
So the guidance and central management of elective care in Wales was significantly delayed compared to what we saw in NHS England. So in the same report, in 2 paragraphs later, that documents that the first meetings were held about elective orthopedic care in 2021, and the first guidance document was released in 2022. So it's fair, and in fact that guidance document is much more vague than NHS England.
In fact, if we look at your report, this is at page 24 and 25 of your report, paragraph 62. I'll just wait for it to come up. It might take a moment whilst we change over. You've set out here the targets that were set in 2022 by the Welsh Government. These are the bullet points that we can see there at the bottom. So no patient waiting more than a year for their first outpatient appointment by the end of 2022. No patients waiting longer than 2 years in most specialities by March 2023. No patients waiting longer than 1 year in most specialities by spring 2025. So is this what you're referring to when you say they were less clear in terms of the mandates and in terms of the targets?
Yes, they're much less clear and objective, and they're not linked with financial incentives, and consequently, treatment delays in Wales are absolutely huge. It's absolutely commonplace for a patient in Wales to wait 2 years or more for a hip replacement, and remains so.
Turning then to Northern Ireland, if we go further down the page, on page 25 of your report, you deal with Northern Ireland and the approach that was taken there with respect to the reformulation of targets in terms of remobilising elective surgery. These bullet points here set out the blueprint. It looks as if it was published in July 2020. Is that right?
Yes, that's right. So there's a blueprint in July. Well, the blueprint in July 2020, which recommended elective care, but the recommendations were fairly non-specific, and I don't think were well adhered to. There certainly wasn't a financial incentive, and in many ways the structure was a similar experience as what was experienced in Wales. They had a review in February 2022 by the GIRF programme, which was initially an NHS England initiative that went to visit Northern Ireland and make a series of recommendations which were much more about having much more focused central organisation of care for orthopaedic waiting patients.
It says at the first bullet point here, by March 2026, no one should wait more than 52 weeks for a first outpatient appointment and inpatient/day case treatment, or 26 weeks for a diagnostic appointment. March 2026 is quite a long way away from when this was first published. Are you surprised by quite how long that target appears to be?
Well, it is certainly later than even the recommendations in Wales, and much later than you would see from the recommendations from Scotland or indeed NHS England. So, yeah, very delayed. And certainly the communication we've had with doctors around the country, those in Northern Ireland are reporting really very substantial delays for surgery. Again, commonplace for 2 or more years, and in some cases 3 to 4 year waits for treatment.
So does this target reflect the extent of the waiting list issue in Northern Ireland?
I would say the waiting list issues in Northern Ireland are really substantial and really long. You know, it's very clear. Well, Wales is clearly struggling. Northern Ireland is clearly struggling, and perhaps even longer. I think the long delay to setting a target, which we've still not reached, is part of the pattern that we see, but is just reflective of, you know, a really quite marked difficulties in the health service there.
That can come down. Reflecting then on all of the 4 nations of the UK and their approaches, you've sort of touched on it as you've gone along, but are there any other comments you'd like to make about the way in which the countries compared in terms of their approaches to restoring elective surgery?
Those are probably the key points. I would say there's a lot of individual variation even within regions, which I think we're going to touch on in further discussion. You know, even within hospitals, within regions, there are quite marked differences that tell us a lot about how elective care can and should be delivered, or might be better not delivered. But I think this central management and incentivisation was quite a powerful thing that we discovered as we were doing the report. It wasn't something I was necessarily had processed as much before we did the report, but it became quite stark as we were doing it.
Turning to once the decision to restore had been set out, there was a need, wasn't there, to identify how patients would be triaged, and prioritisation guidance was set out. If we could go to page 26 of your report and table 2, you have set out here a number of priority guidance, a table which sets out the order in which priority is to be given to procedures. I think at the bottom it should say it says P1A, P1B, P1A, P3, but I think it should say P4. Is that right? Which of these categories would hip replacement have fallen into?
So this was guidance from the combined Royal Colleges, and then other organisations produced very similar guidance whereby you could apply the same kind of triage across surgical specialties. So it goes from P1, which is emergency or urgent, through to P4, and P4 was procedures to be performed in greater than 3 months. So kind of routine hip replacement was very much defined as a P4 type condition. P2, which was procedures to be performed in less than a month. Some cases where the hip had completely collapsed may have been able to be defined as P2 because the document does include arthroplasty where delay will prejudice outcome. So some patients were classified as P2s, and some patients with something called avascular necrosis. So the ball part of your hip joint, if the blood supply to that gets damaged, it can collapse, and it's like similar to kind of a rapidly progressive arthritis picture. They could be defined as P3. So a small number of hip replacement patients could be defined as P2 or P3. Everyone else was very much in the P4 bracket. And I think...
sorry to interrupt.
I'm not sure we're looking
at the same document.
I'm not sure.
I haven't got a P2 on the document I'm looking at.
Yeah,
I think there's a few errors on the document that's on the screen.
Yes.
Yeah, the screen one it's on page...
We're looking at page 26. I don't know...
Yes, it's the same. It says table 2. It's the same layout, but I think some of the P1As have been...
It's been moved. So it should be
moved
P1A,
Yep.
P1B,
P2.
P2, P3, P4. So I don't know where that's come from. Apologies.
Okay. in any event, can I run through what they are then with you?
Sure.
P4, which is where, in fact, you were saying you expect hip replacement to be, that's procedures to be performed in over 3 months' time. That's right, isn't it? Rather than what it says there.
Yes.
P2 is what is in fact now
Less than a month.
less than a month, exactly. It's been removed from our screen.
Our document wizard is thinking about whether he puts in the 2 or the 4, I think. He's already deleted. No.
It might be a bit much to do it on the hoof, but the key point is that hip replacements fell within the P4 category, which means that they were, in this ranking, the lowest ranked.
Yes. So the point of this was theatre time and capacity was very limited. And so rightly, hospitals wanted to use it for the patients in the most need, whether they needed a general surgeon or a colorectal surgeon or an ENT surgeon or an orthopedic surgeon, to maximise the use of limited theatre capacity. So this is not a system that we would normally apply well to orthopedics and to joint replacements specifically. And I think when it came out, there was an overwhelming feeling within orthopedics that it didn't apply very well to us. And because most of our patients would be P3 and P4, they would never get to the top of the list. There would always be a P1 or a P2 that would trump them.
And something that came up before, and her ladyship was dealing with Professor Bangui, was what about the circumstances where someone has been waiting for a longer period of time? How does that impact prioritisation? So
this was the guidance for prioritisation from the colleges. The British Hip Society gave some more kind of more granular and more hip-specific guidance that did indicate some other conditions of the hip that may be a P1 or a P2. And similarly, the European Hip Society also produced that. In terms of long waiters, they were not included in this original guidance, and that was very much left to clinicians to decide whether you thought someone was a P2 or a P3, because that was the only way they were going to get an operation. And in fact, latterly, what has happened is, certainly in my health board, is if you've been waiting longer than 2 years, you get redefined as urgent. Because the problem is with this system and limited capacity, if you're not urgent, you'll never get to the top of the list and you'll never get your hip replacement.
That process, though, and the way in which it's done is entirely dependent on the judgment of the clinician.
It is completely, and there's no agreement on whether, somebody who is working age and is off work and unable to support their family because they've got terrible pain from hip arthritis, whether you give the hip replacement you've got to that patient or whether you give it to the 85-year-old who's housebound at home and is rapidly becoming more frail and isolated and lonely because of that. There's no guidance on how to prioritise between these.
You touched on it earlier when you spoke about how you felt that really this prioritisation guidance didn't that well apply to orthopaedic settings. You also say that you felt that the effect may have been that for orthopaedic patients, they may have been deprioritised as a result of using this sort of criteria. Is that right?
Absolutely. And there's evidence that through the time period in question for the inquiry, orthopaedic surgery was the lowest volume surgery other than dental surgery. So we really, there's firm evidence that orthopaedics in general was deprioritised and hip replacement patients as part of that.
Thank you. That can come down now. We'll try to get to the bottom of what happened there, but that can come down. In terms then, turning to you, Professor, in terms of actually resuming elective surgery, there were some challenges, weren't there, in terms of the way in which the healthcare system had been restructured as a result of responding to the initial waves of the pandemic?
Yeah, absolutely. And I think Professor Bangu explained that actually the problem was largely not the surgeons' availability, it was largely the staff availability, particularly theatre nurses and anaesthetic staff, who of course are probably the best qualified people to support critical care behind critical care themselves, obviously, in the sense that they have those sort of anaesthetic skills that are valuable. So there was a mass redeployment of staff into critical care, particularly, and to support COVID wards. There was, of course, an earlier physical redeployment as well. The space had to be reused. And there's a number of examples of patients being ventilated in theatre spaces, but those were restored sooner than the staff resource was restored. The second challenge was how do we operate on patients safely, and learning this concept of a green pathway. And should I explain what a green pathway means? Is that helpful?
I think we can probably guess, but it would be helpful just for clarity.
Yes. So a green pathway is essentially a pathway in which you are confident that you're confident as you can be that someone doesn't have COVID. And it required quite a few things. Now, the most important step was probably patient isolation before surgery, followed by a test, usually about 3 days before their operation, a COVID test. And the chance of them having COVID, having had a period of isolation and then a COVID test, was very small. But critically, it also meant that you had to have a separate group of staff delivering care for those patients, a separate ward, separate entrances, separate corridor spaces, separate theatres, separate recovery. So there was a physical change to the facility that had to be in place. And some facilities were well set up for that, and some facilities weren't well set up for that. Typically, because a lot of orthopedic care is delivered in acute hospitals alongside acute care, it's, might be Ward 11 or Ward 23 or something, up the stairs, and quite hard to separate, whereas others are much easier to separate because they're already in dedicated units.
It seems that you need, in fact, an alignment between the repurposing of spaces and also the availability of staff.
Indeed.
Did, in fact, the restoration of elective care necessarily align with the ending of things like redeployment or the provision of care being given in different spaces to they were previously?
It was hugely variable around the country. Is the simple answer to that. So we have a growing number of elective focused sites, and in specialist orthopedic hospitals, which are effectively elective focused sites, they were able to redeploy relatively quickly. So clearly, some of their staff had redeployed to other hospitals, but those were mostly restored. And of course, they had the physical space and the ability to deliver those pathways. Other units found it very, very difficult, both from a physical space, physical structure, organisation sense, but also from a staffing sense. And I think that explains the really quite marked variability, even within individual regions.
We're going to look now at the geographical variation, and if we could look at your report and look at figure 12, please. This can come on screen. We have here what's described as a heat map of the proportion of pre-pandemic total hip replacements performed in 2020. It might help if you just describe what we can see in terms of the key with the colours there.
Yes, we've used data on hip replacement volumes. Actually, we received it per month, but we've obviously used 2020 data, looked at 2019 data, and then it divided it by region. So each individual region we've looked at, what did they achieve as a percentage of their pre-pandemic volume? If they're blue, they're achieving above 100%, and if they're sort of yellow, they're achieving a bit below. If they're pink, they're achieving quite a bit below, and if they're red, they're way below.
So if we come back and look at it in the round, what is the message that we can see from this diagram?
Well, the first message is it's really patchy and variable. This, and then I'm sure we'll come to a 2021 version, and we'll see actually there are more, the reduction in services was more marked in Wales, Northern Ireland and Scotland. And then across England, very variable. Even when looking at this, we've got to be quite careful. So in my region, there were really marked differences to the point that now there is probably a difference in waiting times of a year, whether you drive half an hour down the road or not, between different hospitals. So you can really have quite marked disparities, even in small regions, often because one hospital's set up one way and one's set up another.
In terms of national differences,
Yes.
can we derive any messages from looking at the map here?
Yeah, indeed. From this map, and indeed from multiple of the figures presented in the report, we see that in general, England was better able to restore, but very variable across the country, but better able to restore its activity. Scotland less well so, but had some pockets of excellence, pockets of real success. Wales less so again, and in fact there's multiple figures show that the delivery of restoration of elective care in Wales was really, quite a long way behind, and Northern Ireland even more so.
And if we go over the page, we can look at 2021. It's or it should be slightly further on.
Indeed, yes. And I think this is telling both because of how red Wales is, but also interestingly, Scotland's quite interesting because there's a patch that did really very well in the centre of Scotland, and that was representative of one specific trust, I believe, who were much more able to restore their activity using a sort of elective care hub model.
So One Health Board in Forth Valley did prioritise the delivery of elective care and actually exceeded their previous volume of work in terms of elective surgery. They've subsequently also become a national treatment centre, so that was happening in the background that they were expanding. The Golden Jubilee Hospital, as well as a kind of national treatment centre for Scotland, obviously was protected as well. So those two units have kind of driven this, but the rest of Scotland remained pretty dire. Certainly locally we had, until not very long ago, 4,500 people waiting for hip and knee replacements in my hospital alone. So it is very patchy, and interestingly as well, the centre that did prioritise elective over the front door had significant front door issues as a consequence, and problems with the emergency department and the acute medical unit.
Is it right that hospital, I think it's the Golden Jubilee Hospital, it does take patients? Sorry.
So no, that dark blue there, that is Forth Valley.
That's Forth Valley.
Yeah.
And the Golden Jubilee Hospital
the Golden Jubilee is its own health board, and it's based in Glasgow, and it does take it takes patients from the whole of Scotland. But different health boards have different arrangements with it. So it doesn't take patients from across Scotland based on some national waiting list. It takes patients based on X health board sends 100 a month to the Jubilee, that kind of arrangement, rather than a national waiting list.
That can come down. But is it right that during your research you identified that actually there was a correlation between the areas of greatest deprivation and the highest deficit in terms of restoration of hip surgery?
Yes, that was not. The figure shows a small but definite change effect of deprivation on the waiting times for surgery, or our ability to restore elective surgery. And I would also comment that the sort of central guidance allowed some of that, allows it to, it prevents inequalities because it allows the trusts that are most suffering with pressures because of their sort of demographic to best deal with, to address elective care priorities as well. So otherwise, those centres that are most under pressure from their acute side then also deliver more delayed care on the elective side, which worsens the problem of inequality.
Is there also a link between the types of patients who may seek care for hip osteoarthritis?
I'm sure that's true. It's a thing I couldn't say we have strong data on, but I'm sure there is lots of evidence across healthcare that those who are more socioeconomically deprived have a lower rates of healthcare seeking and lower rates of healthcare engagement. And I'm sure that would be true.
Finally, on restoration of care, Professor, do you consider that the independent sector was sufficiently utilised to restore this type of care?
Well, I would say Professor Bangu quite rightly said that it was used largely for cancer care, and he felt that it was well mobilised for that, and I'm inclined to agree with him from what I've heard. It wasn't really used for orthopedic care. There was only so much capacity, of course, and it was pretty quickly returned to its original function in independent sector care, in which case they resumed activity as they would normally do so. But in terms of NHS delivery of care in the independent sector, it wasn't really used for orthopedics at all. Or with very small numbers it was, but at very small rates.
Next, the impact of the delays which were caused by the pandemic and the decision to suspend elective care. If I start with another passage of your report on screen, please. This is section 2.3, page 19, where you set out here the targets. Apologies. It should be, yes, here we go.
Yeah.
In England, the key targets we see here is for elective care such as hip replacement to have a referral to treatment time of 18 weeks and all care to be completed by 52 weeks. Then we go to Wales and we can see there that 95% of patients should have a referral to treatment of 26 weeks. No patients waiting longer than 36 weeks. Go down to Scotland and we can go through, again, 90% of people should not wait longer than 4 weeks from referral by a GP to be seen by an allied health professional. And then Northern Ireland, there weren't specific targets, but the current ministerial waiting time targets state that 50% of patients should wait no longer than 9 weeks for a first outpatient appointment, with no patient waiting longer than 52 weeks. The first thing that arises from looking at this is it appears that there are various different ways in which the nations are measuring their ability to perform total hip replacements. Is that right?
Yeah, that's absolutely right. Yeah.
And if we could take that down, is it right that actually this lack of consistency in terms of the data and the way in which nations are measuring their success in terms of performing orthopedic care makes it very difficult to actually assess and compare the impact of the pandemic?
Yeah, it does. I mean, actually, it's very hard to get referral to treatment times for hip replacements at all. We haven't been able to provide that data. So the way it is measured, it also tends to be collected in aggregate by specialty. But if you think of a specialty of trauma orthopedics, it's hugely diverse. So, carpal tunnel operations, you could do a lot of those in the pandemic because you didn't need an anaesthetic and you needed a lot less physical space. And you could, so there was a long period where a lot of day case operations were being performed, but not hip replacements and knee replacements. Because, of course, they require a general anaesthetic and are a big operation and a recovery space and a ward. So the waiting times that are stated are often poorly representative of what actually happened to people who had joint replacements. And I think that's quite important to recognise. We can be overly reassured by waiting times by specialty because they contain a multitude of different issues.
You can use the data then perhaps to spin whichever message you wish to send, is that right?
Well, yeah, to some degree. I mean, in many ways, if you've got a large number of people who are waiting a long time, you can be pretty confident they've got a lot of people waiting a long time. But if you can't be reassured by, say, a median figure of, X number of people, X percentage of people achieving this in trauma orthopedics, because you might have just done lots of local anaesthetic procedures and not many hip replacements. And we see that, I think, so to compare in England and Wales right now, there are very few people in England waiting 2 years for treatment. There are 23,000 at least waiting for that time in Wales. So for orthopedic care, so that's at least that was a press release recently. So that's the sort of figures we should be, cautious of.
Do you think then there would be value in having uniformity of measures in terms of how to assess someone's waiting time across all 4 nations and across the individual countries as well?
Indeed, yeah. I think uniformity of data and sufficiently granular data that it is meaningful would be really valuable.
Were you, though, able to, in general terms, ascertain how much of an impact in terms of delays the initial decision to suspend and indeed the pandemic generally caused?
Say that again.
Are you able to ascertain at all
Yeah.
what level of delay can be attributed to the decision to suspend elective care?
Well, I think we can say that. We can say what percentage of hip replacements weren't done compared to what we'd expect. So in England, for example, only about, I think it was, there was a 46% reduction, consistent with about 50,000 less people having hip replacements in 2020 compared to 2019. You can ascertain how long you would expect that recovery to be to bring them back to previous standards, to bring them back to the sort of waiting times people are achieving. We know that's going to be a number of years. So we can ascertain that waiting lists are definitely longer, definitely variable, and longer in the devolved nations. It's actually quite hard to put an exact figure on exactly how much, but we can be pretty confident of the sort of scale.
Taking a step back, does it follow then that you said earlier you didn't criticise the decision to initially suspend elective surgery? The issue here is about the variability in restarting it.
Absolutely. Yeah.
In terms of internationally and comparing internationally, at paragraph 146, you deal with how the UK has fared internationally. How did it fare?
Very poorly, is the simple answer. So I think we have a figure which shows from the OECD, so this is data that compares, here we go, figure 25.
If we could get that on screen, please, thank you.
This compares the United Kingdom's performance against multiple other EU countries. To put this in context, for hip replacement...
24.
So page 62.
Sorry, figure 24.
Figure 24, sorry, if we could go back a page.
So the UK chart is pretty obvious because that's the lowest one by far towards the right of the screen. So the EU block percentage in terms of the reduction in delivery of hip replacement over 2019 to the change between 2019 to 2020.
Just the top one.
EU average was minus 14, UK average was minus 46%. And we were by far the worst performing country.
What are the main factors for the UK performing so poorly?
So I think we have to reflect that the UK was already struggling to meet demand. So the supply of elective orthopedics was already falling behind, and waiting lists were already rising before the pandemic. I think we have a lot of mixed acute and elective care delivery that meant that responding to the pandemic was incredibly difficult because we couldn't deliver the green pathways and the separated care that could have happened if we'd had more of an separate elective and acute setups in the model of a sort of elective care hubs. And I think that's probably the biggest change that would allow us to be more resilient in future pandemics, would be the ability to have elective care hubs that are physically distinct and can deliver green pathways and deliver care efficiently and effectively, is probably the biggest difference. I think the overall capacity in the NHS is definitely a factor as well.
You touched on elective hubs, and you describe in your report an example, or two examples, in fact, of innovative practices. One of them is at the South West London Elective Orthopedic Centre. What did they do that was different to the general approach?
So they are a ring-fenced elective orthopedic unit and physically ring-fenced in the sense that their whole facility is physically separate from acute care. So that allowed them to deliver green pathways very efficiently, allowed them to utilise their staff resource effectively, and allowed them to restart much more efficiently than others. And in fact, if you look at their performance, they've outperformed the rest of the NHS consistently since the pandemic. And that, I think, is reflective of a separate elective hub structure that's physically distinct and allows the organisation to plan very much and to deliver this care efficiently. What's also very good about it is it takes staff from other trusts in the region, so it's not attached to a trust, which means that you can develop a network of trusts that aren't undermining the ability of other trusts to deliver. They're actually supporting the ability of trusts to deliver in the region. And if I may follow on to the Exeter Centre as well, so Exeter used a Nightingale hospital model to deliver elective care, and this was for the Southwest. So the Southwest was one of the poorest performing regions in terms of its ability to, in England anyway, one of the poorest performing regions in England in terms of its ability to restore elective care. And it's been absolutely transformed by using a Nightingale unit and opening 2 extra elective theatres. And that, again, is trust neutral. It's not, it's bringing in staff and surgeons and other staff from all sorts of trusts in the region to deliver extra capacity. And they've gone from waiting lists of 2 years to well below 1 year, 9 months to a year already in a very short space of time, actually. So it's demonstrating that these things can be done, can improve your capacity, and can make you much more resilient.
Turning to the overall messages, if I could start with you, Ms. Scott, what is your overall message from reviewing what went on during the pandemic and how it's impacted orthopedic care and hip replacements?
So I think it's clear from all the data that orthopedic surgery was deprioritised more than other specialties. And there are a lot of lessons that we can learn from that deprioritisation and from the lack of ability that certain regions have had in restoring elective surgery capacity. And I hope that we can then apply those to what happens not just in the next pandemic, which is obviously the point of this inquiry, but what literally happens every winter to hip replacement patients. They always get cancelled and deprioritised first. So the lessons I think that are key are in the pandemic response, a centralised decision-making, I think, is key. And where that happened with specific quantified targets in England, it gave trusts the ability to respond and restore elective care much better than it did in the devolved nations where it wasn't mandated. Recovery was not mandated. It was left to individual health boards to decide whether they had the capacity to do that or not. And that has led to massive regional variation. So I think better top-down messaging in terms of mandating recovery is fundamental. I think inter-trust sharing of waiting lists and patients is also fundamental. It's not fair that if you live in one location, you have to wait 3 years for your hip replacement, and if you live half an hour down the road, you get it in 6 weeks, which is the level of disparity that is being experienced currently. So that would be my 2 key messages, and I'll hand on to Andy for...
Yeah, and I wanted to follow on with the experience of elective care hubs, which were clearly essential in both the ability to restore care and then transforming care when we realised that there were backlogs, and then the ability to deliver elective surgical hubs to deliver focused care for those patients, I think is transformative to our resilience for the future.
Thank you very much. Those are my questions, Madam.
Before I ask, Mr. Thomas, I think, has some questions for you. Can I spring on you the question I sprang on the Professor this morning?
Of course.
Professor Bangu. Were either of you redeployed?
Do you want to go first?
So my practice was, prior to the pandemic, was 50% joint replacements and 50% trauma. So my joint replacements disappeared immediately. But trauma kept going. So I was full on trauma, and we helped with proning in ITU and things like that. But I wasn't, fortunately, redeployed to a completely different department because trauma kept on coming.
So I was, in the first wave, I was redeployed to help deliver minor injury care. So we actually set up a separate minor injury unit in our elective footprint to take the pressure off and physical space off A&E. In the second wave, I did a few shifts on intensive care unit, although much less than my junior doctor colleagues, I have to say.
And were you consulted about where you went?
Yes, so similar to Professor Bangu's answer, with a department, certainly when we made the first decision, we sat down together as a department and said, how are we going to help and how can we support the hospital? And we split ourselves into, like Chloe, a group delivering trauma and a group delivering minor injury care. In the second, there was a request for it was very much a voluntary request, but a request for support for intensive care, and we as a department sat down and agreed that would be appropriate, except in cases where people didn't feel they were able to. So yes, we did agree on that, but it was quite an experience.
I can imagine. And not one you'd wish you relived, no doubt.
No, very challenging, very challenging.
Mr. Thomas.
Good morning, Professor. Afternoon.
Good afternoon.
Professor Metcalfe, Dr. Scott. I only have a small handful of questions for you. I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations. In paragraph 136 of your report, you discuss health inequalities related to total hip replacement access. And there you note disparities in both utilisation and outcomes amongst ethnic groups. Could you share your view on whether targeted public health initiatives are necessary to encourage greater uptake of elective procedures such as total hip replacement in these kinds of communities? And if so, can you assist the inquiry with what might such initiatives include?
So I would support Professor Bangu's answer to a very similar question, which I thought was excellent. I think we need significant research on how best to engage in the wide variation of ethnic and minority communities, and how to ensure that people feel they can access care appropriately. Now that is very much not a one thing fits all. It means engagement with community groups, engagement with cultural groups, engagement with religious groups, in terms of understanding how people should be communicated with and should be engaged with, and improving trust as well in the community. And I think there's a combination of confidence and trust in communities and their ability to engage with healthcare. And that is definitely a thing that needs to be addressed.
Can I just piggyback on what you've just said? Are there any examples from other health organisations or that could serve as a model?
That's a very interesting question.
It's my understanding, specific to joint replacement, is there's a lot more research coming out of the United States, for example, in terms of racial disparities in access to joint replacements. There's also gender disparities in access to joint replacements. It can be difficult, and deprivation issues and what have you. So I think it's certainly something that needs addressing, not just in joint replacement surgery, but probably across the board in all healthcare.
Let me move on to my second question. Moving on to the impact of the pandemic on elective surgeries, has the pandemic exacerbated delays in procedures like total hip replacements for ethnic minority patients as compared to other groups?
So we know there was a relationship with social deprivation, and we know that both proportions of ethnic minorities and social deprivation are often interlinked. So it is likely that there was. We don't have data on that, and perhaps some of the point that was being discussed earlier about granularity of data, then actually granularity of data in terms of ethnicity, gender, social deprivation would be valuable if there was a way of making that available, and that would improve our ability to, because ultimately the availability of data allows you to act in a
more targeted way and motivates change. So I think that sort of granularity of data would be really valuable. Okay, let me come on to my last question. From your perspective, how can healthcare providers improve cultural competence throughout hip replacement care pathway, from diagnosis through to post-operative recovery, to ensure that ethnic minority patients receive equitable and culturally sensitive care?
Do you want to start? Or?
So I think part of the barrier often is a lack of diversity within orthopedics itself, and actually if orthopedics itself could have a more diverse workforce, then it may help more diverse individuals, regardless of the reason for their diversity. It might make them more confident in accessing healthcare for their joint problems. So that's certainly something that is in the spotlight at the moment and definitely needs work, but lots of people are working to try and improve that.
Yeah, I would agree. And again, I would follow on from Professor Bangu's suggestion that there really should be much more research in this area. I think we recognise it as something we could do better at. I think as clinicians and in fact our clinical bodies recognise that this is an important issue we need to improve on. I don't think we're there yet in terms of our ability to do that well, and I think we could be a lot better, and we probably do need to invest in research that focuses on that.
Thank you very much. Those are my questions.
Thank you, Mr. Thomas. I think that completes the questions for you. Thank you both very much indeed, Professor Metcalfe, Ms. Scott, for all your help in preparing the report, for making it understandable, and for all your help today. I'm really grateful to you.
Thank you very much.
Thank you.
20 to 2.